tension of urine. He's diabetic, he's hypertensive, and has ischemic heart disease. So this is not the perfect patient, but we see an increasing number of patients like these. You see he's on antiplatelets, his cardiac condition is not that good, and he has a nice sized prostate, 90 ml. He already had alpha blockers, because obviously when you having a higher comorbidity, your GP or your urologist would say, let's try first alpha blockers. And he failed on a catheter-free trial. Stavros, what would you do next?
Again, this is a challenging case, but the problem is that more often we face cases like this. So we have a patient in retention. So it's not, about if he voids well or not. So we need to do something for him. The problem is that he's under, all the cardiovascular problems he has, but also he's under antiplatelets. So we need to explore the options we can offer to him. We can always do any kind of surgery. We can discuss with him, about the risk. We can do an TURP. We need to have a consultation with his cardiologist to see how can we manage the antiplatelets. We can stop them for a few days if we have only TURP as an option to offer to him. If we are in a good center that we have more treatment to offer to him, we can discuss to offer him a laser treatment. It will be a laser ablation. I think that we know very well from the data that laser ablation have, are more indicated for patients who are antiplatelets. We can even not stop the antiplatelets and do the ablation. Should we go for enucleation? We have some data about that, but still, again, with enucleation, we have an increased risk of bleeding compared to ablation. So it depends on the available techniques we can offer, but the most important is to discuss with the patient the risk and also to have the consultation with the cardiologist. So it's not, when you see a patient like this, you say, oh God, I don't want this patient. But at the end, this is the patients we deal with, and we can do a good job with any technique. If we have all the modalities, I would go for a laser ablation.
So I think makes sense. We are in surgical management. So Thomas, if I come in your place, would you offer him some alternatives, minimal invasive alternatives? So where you avoid any, call it surgery.
I learned something last week. I do my pre-operative counseling on Tuesday afternoon, and I said everybody has to get through all the self-reported questionnaires, and I had a patient who was on suprapubic catheter for 2 years. For reasons I don't want to explain, but he was on 2 years, and they gave him the IPSS, the ICIQ, and the IEF. And then the nurse said to me, but he's on catheter. And I looked onto the IPSS, and the IPSS was 0-life quality 0, which means he had an excellent quality of life with a suprapubic catheter. I didn't realize this because, if we step into this case, of course, he needs some kind of urinary diversion, either through transurethral catheter or suprapubic catheter, because this patient will not void even if we do anything. This looks like 2.5 or 3 liter bladder volume. We know that after 1.2 liters, we have a detrusor underactivity. So this patient, whatever you do with him, will have some postoperative complications like bladder neck stricture or urethral stricture, or he cannot void, although he had a nice treatment transurethrally. And therefore, I would today discuss with the patient whether he would like to try out the suprapubic catheter, which he eventually needs prior to treatment anyhow, or at least in my hands or in our institution, he has to have it for 3 months to recompensate the large gross distension of the bladder. And then if he feels happy with it, he could stay on with it. He's 68 years old. He has diabetes, so he has probably a neurogenic pathology, neurogenic bladder, and he has ischemic heart disease. So he will have he will not have 20 years of lifetime. So, and after that, 3 months, we can basically do everything with it, what the anesthetist allows. And I just want to address this. You don't only have to plan for one treatment, you also have to have in mind that you eventually have to do a second treatment followed by that. But so, of course, I believe in enucleation. I think that the only way of allowing people to avoid with a detrusor under or acontractility is enucleation. We just published a systematic review on that, which provided the evidence that actually it's very helpful, unlike TORP, and therefore that would be my option in this patient after recompensation of the bladder.
So Ago, patient was taken up for evaluation at a large and extremely vascular gland. And when I got this case, I like this when the urologist says he has large arterial bleeders from the word, let's go for it, which means either he's going for bleeding or you can control it. Compromised medical status. Anesthesia time may be a cause for concern. Now, Ago, if you see this nice big middle lobe, not middle lobe, but he has this one big vascular lobe. What do you think? What would you do?
Well, this is a patient that would be a real nightmare 20 years ago, really, because it was a patient for which at the beginning of our experience in this job, we cancel a catheter, a bladder catheter, and go away, please. And nowadays, unfortunately, this is no more the case. And in this patient, if the patient is so compromised that the prostate is 90 cc, I would start with the median lobe enucleation and stop, because I try to limit the surgical trauma and see if the patient will void. Probably there will be a successful strategy because our aim is to let the patient void in a reasonable manner, not to perform a complete enucleation if the clinical situation is so frail, you know, and we risk a lot of huge bleeding with any technique. Obviously, with the laser or bipolar enucleation, the intraoperative bleeding is absolutely it's easy to control, and the patient is supposed not to lose a lot of blood. But I will offer him a surgical procedure just to let him be free of catheter or suprapubic tube or whatever else.
So, Cecilia, in this case, the colleague decided to remove, you can see this swinging lobe from the left, to remove that completely and left the other lobe untouched. Is that something you would consider? And if yes, would you go for a second stage? Or would you say, well, if he voids, I let it like this. I just remove one lobe.
So the most important thing is, to me, what we said with the patient before surgery, which is the plan, because we have to talk to the patient and do some exams. And in the previous slide, you can see very well how important ureterocystoscopy is for a diagnostic decision. So probably the most important thing now, if the deal with the patient is to try to be without the catheter, the deal should include the perspective of self-catheterization, because the bladder we have seen in the MRI is really very distended, very thin, and probably, as Thomas was saying, with the detrusor underactivity. And so probably the goal is not to void somehow, but to have a low residual volume, and so to be able to do self-catheterization. And you have to see whether removing only one lobe is enough to do self-catheterization without bleeding, because you have to educate the bladder again to void somehow. And so you have to evaluate the outcome of the first procedure and then decide for further stages.
The interesting thing is, there was a study done in Scandinavia many, many years ago. Most probably nobody reads the literature anymore, where they did a proper TURP, both lobes, and one lobe only. And they offered the patients, after half a year, that they could resect the second lobe. And the vast majority, 90% or so, said, no, I'm very happy with this. So it doesn't always work, but I think if you have compromised cases, to remove one lobe only would be okay. So in this case, again, it's a real life case. Catheter was removed on the third postoperative day. He voided well, was discharged from the hospital. It was symptomatic on follow-up. But it's interesting. I think all of you said, we don't expect this because his bladder was over-distended. Most probably didn't work well. So there are always exceptions. It can happen, but we should discuss with the patient what are his expectations and what are our expectations. And obviously, sometimes we are too optimistic, and sometimes it's better to be a little bit more pessimistic, that afterwards the patient says to us, hey, doctor, don't worry, you see everything worked out well, instead the other way around. So hemitope is a valid option, and you shouldn't do it in every place, but in every case, but I think it's an opportunity to think of advantages. When you remove one lobe well, at least to my colleague, he says there's no falling in of the residual tissue and no bleeding or absorption from raw surfaces. So only do one lobe and do it well, or make a channel, and that should be enough. And I think it was a nice case for an illustration that how we can handle. But nowadays, maybe many of us would offer, let's say, a Eurolift or a red zoom or whatever. But this is still a very valid option. So let's move to the second case. The second case is prepared by Dr. Meneghini. Ago, it's yours.
Here we are. This is a nice case. This is an 83-year-old man, which in 2012, for a PSA of 5.7, in a suspect distal examination on the right lobe, performed a prostate biopsy with a 4+3 Gleason score prostate cancer on 12 biopsies. The stage was negative, and the patient didn't want any surgery. It was 71 at the time. They underwent an external beam radiation plus 2 years of androgen blockade therapy. The PSA rapidly had its nadir with 0.01, and it was stable even after the interruption of the medical therapy. At that time, you have a normal body pattern for a long time. What happened after? From the beginning of 2022, the patient reported lots, 2 times per night, hesitancy, poor flow rate, and the sonography has a 135 residual volume. He had a control MRI with a Pirates 4 on the right apex, and prostate is not so big, 35 cc prostate volume. It was put under combination therapy, but the results were really very disappointing. And the patient came to me asking for surgery. What will we do? Will we do for AEP, irrespective of the power source, or a standard URP?
So let's ask Jean-Baptiste, because Jean-Baptiste is a small prostate. Would you go for enucleation, or do you still have the normal offer for TUR?
I think it's possible to treat the patient with a laser surgery, but I probably won't do a total enucleation of the prostate. I probably am going to use a thulium laser and probably do something partial. So disobstruction of the bladder neck and disobstructions with the endoscopic view I have, but not, I won't be very extensive at the apex of the prostate because the risk of incontinence is huge with this patient. But it's possible to treat him with a laser to try to reduce hospitalization stay and catheterizations in time. But we're going to have very careful with what we are doing. So I'll probably do, it's going to be what we call a thulium vaporesection. That's going to be it. It's not an enucleation. It's a disobstruction with the thulium. And with the thulium, it's possible to cut very easily inside the tissue. So I will use the thulium because I think that HOLEP is better for enucleation, but I will use the thulium just to disobstruction of the patient, keeping a very important, careful about the apex during the surgery.
Good. I have quickly 3 questions to each one of you. Jean-Baptiste, why thulium over holmium? And I want to ask this to Cecilia and also to Thomas. Why thulium over holmium if we talk about enucleation? Why?
First, I won't do an enucleation in this patient. I will just do a disobstruction of the urethra. And that's the reason why I'm going to use thulium, because it's very good to cut inside the prostatic tissue and it's very hemostatic. So I will use it for this two. It's possible to do with the thulium enucleation, vapoenucleation, vaporesection, and I will probably do the vaporesection for this guy.
Okay, Cecilia, you are also demonstrating a case with thulium. Why would you choose, if you do an enucleation, thulium over holmium?
My case is TFL, not thulium YAG, of course.
Sorry.
And, we don't use thulium YAG, in spite we have tried it. And I agree, this could be the good case for thulium YAG, the hybrid one, probably. We would use TFL or holmium. For me, it's the same. But in this case, I wouldn't do an enucleation or a QRP. I would do an endoscopy and try and see whether urolift could be a good solution for the patient. I would really go for minimally invasive things because of the risk of incontinence, but with a good pre-operative evaluation.
Okay. Thomas, you're Mr. TULEP. You invented it. At least that's what you claim. Why TULEP better than HOLEP? Help us for the laser.
Oh, I would agree with Jean-Baptiste. I would not get out the full template. What we are missing is a sagittal plane. So if he has, so we have, we just popped it up on other screen. We have a good amount of data with median lobe enucleation in various scenarios. It works very well in quality of life improvement in small IPP and large IPP, but even in no IPP. So I would go for median lobe enucleation with whatever energy source I have on that day. I think that Jean-Baptiste is right. The thulium YAG is very good. I think it's the only from those laser probes that we know that vaporize as well. I agree, but I would not go for vaporization because I think that the surface is not too nice. This is why I go for median lobe enucleation, which offers a good deobstruction in the midline. And probably I'll do this in all cases, which I do a partial treatment of the prostate. I would put in a suprapubic tube to estimate whether this patient can void well, because they can go for bladder training after that. And if it's not sufficient, then you can go on the second stage to do something else. But I actually, what Cecilia said, to evaluate for other treatments like urolift in the small gland of 35 would probably work out, or mesonym would work out as well. But I would prefer median lobe enucleation.
So obviously, all the experts agree with disagreement. No, there are different roads to their goal and the target, and we need to keep this in mind.
We agreed we agreed that we would not do the regular stuff, full TORP and full EEP. So that is at least where we agreed on.
If I may say, if I may ask something, do you expect any difference in the tissue reaction because he has received radiation? Because, we know, at least we have experience, with patients who develop retention and they are for years under complete androgen blockade. And you know that the urethra is a little bit stiff and, the maneuver is not so easy. So, about the enucleation of the laser, do you expect any different reaction because of the radiation and the previous androgen blockade? It was 10 years ago, I know. But let's say if it was 1 year after the radiation.
The only thing I can comment on that, if I may, the only thing that is really awful is after LDR brachytherapy. but I didn't find any difference after radiation, whole gland radiation, if you just do a limited TOR, channel TOR, or a median lobe enucleation.
Ladies and gentlemen, we go to the third case. That's a 65-year-old male, body mass index of 55, is enjoying the soft life, a little bit diabetes, a little bit infarction, a little bit hypertension, a little bit pulmonary problems. In other words, a recognizable gentleman. But he had a laparoscopic cholecystectomy, so we could not undergo this. He had a left knee surgery in the past. The only problem now, he's a little bit unable to lay down. And he's also a little bit anxious. He has an anxious depressive syndrome. And this guy comes to you and you think, lucky, lucky, lucky me. Because obviously he wants to have some treatment. And treatment is related to his male LUTs. And he has it since 2015. He failed medical management. And if you look at this, we'll make an ultrasound, you say, let's start a little bit, bladder wall is a little bit thick, prostate volume is rich, and his kidneys are okay. So what could we do next? Ago.
Well, I will go to Sant Antonio Church to have a benediction on my hands before starting, because I think that is a case very complicated, because the patient is not exactly a good surgical subject, and the prostate is huge. Anyway, talking with the patient, we'll start for enucleation. It's a longer job. The patient would, I hope, it will tolerate the anesthesia and will not have any intercurrent problem. But I think that this is a case for an expert enucleator. But I think that with a nice holmium laser or thulium laser, this is a task that can be afforded quite easily. And I think that there will be my choice, because I would not go for anything else. I think that even an open prostatectomy or even a robotic one would be so simple in this case. Probably if sometimes you can read in the literature, the patient can undergo to a stage procedure. I mean that you go try to remove this huge median lobe and then go after the other part of the prostate. The patient avoids in a reasonable manner. You can stop it. But today I will not be so much afraid of treating. I will hope that with this patient will go to Thomas or to Jean-Baptiste instead of me. But if the patient is knocking on my door, I will not send him away.
So again, this colleague offered this patient with this enormous prostate. And again, keep in mind, a patient that is a case from some years ago. He offered TURP 25 grams, another TURP 28 grams. But the question is, if with that, the whole problem is solved. And obviously, when you have difficulties with anesthesia, high comorbidity, sometimes you need to go up to alternatives. But I think here also the UroLift will not really help,
Jean?
Yep, Stavros.
I'm very happy that I work at the hospital. We have an excellent interventional radiologist. So maybe I would send this case to my interventional radiologist for a prostatic artery embolization. Maybe,
Okay.
This treatment would work, but I would expect at least a kind of shrinkage of the prostate and less bleeding if I had to go to the operation. So this could be a first step. I don't know if it would be successful or not, but this could be also another option for this patient.
I like that. Cecilia, what do
Yes.
you have for us in mind? This
I
patient.
have an observation. If the images of the ultrasound were his images, there is a very huge intravesical protrusion of a median lobe. So it's a 284 cc prostate, but probably 100 cc's are into the bladder lumen. And if you do a nucleation with any laser you like, probably it would be a good advantage and the procedure could be very efficient and give good results. The only deal, as usual, with the patient has to be that he has to expect some post-operative stress urinary incontinence because of the thickness of the bladder, because of the obesity, of course, and because of the size of the prostate. And since I've seen some questions on the case of before from the audience, they were asking for pressure flow studies. Sometimes it can be useful in case of underactivity to confirm it, like in the previous case. In this case, to exclude overactivity, of course, it depends on how easily you have access to these exams. So this is something I wanted to say to the audience. But enucleation, laser enucleation could be a very good option for this patient.
Case number 4, Cecilia, it's all yours.
Oh, yes, thank you. So this is a 53-year-old man, no smoker, with a normal BMI, a low anesthesiological score, with a recent onset of rapidly progressing LUTS. Nothing relevant at the past medical history. And at the digital rectal examination, the prostate is not so big, it's not painful, it's not suspect, the PSA is very low, negative urine culture. He started with an alpha blocker. He had a clinical improvement, but he complained about retrograde ejaculation. So we went on studying the case with abdominal ultrasound. The prostate is a 35 cc prostate with a post-void residual of 50 cc, and the uroflowmetry before the alpha blocker was pathological, flat and prolonged, and you can see the IPSS and quality of life values. So we have to decide what to do with this patient. Discontinue alpha blocker, change it, start on other kind of therapies, other medical approaches, or go for any kind of surgery, TURP, minimal invasive surgery, transurethral incision of the prostate, or what else? So this is a question for everybody.
Jean-Baptiste, you are now everybody.
So the question is for me, is the alpha blockers are selective like silodosin alpha blockers? If it's silodosin alpha blocker, I will change it for alfuzosin or tamsulosin, which is going to reduce the risk of retrograde ejaculation, first. Second, when I see the APSS and the quality of life, probably the patient won't go to surgery. I don't think he is going to go for this. What could be an alternative for him? Could be Rizom, I think. That could be discussed with him, or UroLift, or if the patient wants to go to a definitive surgery, so I will discuss with him, fibertullium treatment with ejaculation sparing disobstruction. That could be an idea. But when I see APSS, when I see quality of life, I think with my patients, the patient will stay like this. So I don't think he's going to go for an endoscopic procedure because it is not so bad.
Okay. So Cecilia, help us.
You know that I always say the same things. We like pre-operative endoscopy because I think it's diagnostic, and you can see the guidelines, the current EAU guidelines, perform ureterocystoscopy in men with LUTS prior to any kind of the surgical decision if the findings may change treatment. And the strength rating is weak, but in this video you can see we performed the cystoscopy, and actually the two lateral lobes were not obstructing, but there was an obstructing middle lobe. And so this is the value of pre-operative endoscopy. And what the patient did, he did the TFL laser enucleation of the middle lobe only in 25 minutes of total minutes of surgery, 10 minutes of middle lobe enucleation, 8 minutes of lasing time, 16 kilojoules of energy used. You see the settings that we have used, which are our usual settings. No more sedation because the middle lobe was really small and could be resected in 2-3 pieces by the bipolar, and the weight was 12 grams.
So Stavros, you have been chairman for many years of the EU guidelines on BPH. Is that something worthwhile to revisit for the guidelines? Just a middle lobe resection? What do you think?
Yeah, guidelines depend on the available data. So actually, we don't have any real studies on the resection of the middle lobe alone. So this is the problem. Obviously, we know that the presence of middle lobe can change our approach to the management of the patients. But I would also like to ask Cecilia, how do you advise your patient about the ejaculation preservation? Because as Jean-Baptiste said, I think that the main problem of the patient was the ejaculation disturbances due to the alpha blockers. So how can you guarantee that he will preserve his ejaculation after even the enucleation of only the middle lobe?
Okay. I always talk a lot with the patient. Of course, we did what Jean-Baptiste said. We changed the alpha blocker from tamsulosin to silodosin, of course, and the results were not satisfactory. But the patients continued to complain about LUTS because he stopped, discontinued, and took again the drug, the alpha blocker, so he had problems. I cannot guarantee antegrade ejaculation, but we have a small series trying to implement it now of middle lobes only, and the results in terms of antegrade ejaculation preservation are very, very good. More than 97% of antegrade ejaculation preserved. So I know it's not yet published. We should publish it, of course. And these are our results. I never guarantee anything to the patient because in medicine you cannot guarantee 100%, of course.
But in this case, the outcome was good. I see he had integrated ejaculation and his voiding was okay.
Yeah. Thomas, you had a comment maybe?
I agree with you and I agree with Stavros. And as you know, I proposed middle lobe enucleation 2016 at TFL.
Your voice, Thomas.
Can I be heard or not?
Yeah, perfect.
Okay. I fully agree with what I've heard. I just wanted to add, and as you know, I proposed thulium-yak, middle lobe enucleation in 2016 at TNT, actually, in Torino. And we have now data since 2022. We have the data of median lobe enucleation in press. And it's, as you say, it's around 90% antegrade ejaculation in literature. And we have the data, retrospective data of Stephen Kaplan, who's now very fond of aquablation, as we can read on Twitter and LinkedIn. And he had a retrospective series of median lobe resection, resulting in 97% antegrade ejaculation in a 12 years retrospective series of 12 years follow-up with minimal redo surgery due to obstruction of adenoma. I think that's really a valuable one. But in this case, if a patient with an IPSS of 5 and life quality of 2 is still not happy, you really have to look for his ejaculation. Otherwise, you will end up with a strange situation after surgery if he retrogradely ejaculates.
It's nice to see that we have some data coming up. And I hope that with the more publications, we will be able to address this. And as you see, there are some pros and cons. I would like just to get them on your eyeball, because I would like to conclude with the last case, which is the nice case coming from Thomas. Thomas, this gentleman visited you some time ago, I think. I Googled, and I see an increasing number of senior people who look like this. Tell us a little bit about your case.
Now, this was not the fault of my patient, of course, but my patient looked virtually quite similar. And he is, as the person, as you just saw, he's a very famous person in the United States offering various products of supplementary
You need to
diet.
speak more clearly to the microphone.
Actually, of course, this is not the picture of the patient, of course, but this patient picture, what we just saw, is a very famous doctor from the United States, an endocrinologist who is offering a lot of supplementary diet in the internet, and he's actually looking like this with more than 85 years. And this patient looked similar, and he has the same profile. He's an endocrinologist, and he used for more than 45 years androgen substitution. So he was on one hand very happy with his physical stature, and on the other hand very unhappy with urgency incontinence for more than 15 years, and he had a chronic prostatitis since 5 years. And I was approached as a fifth doctor to solve the problem. The previous had suggested to him BNI and suprapubic catheter. What made him come to me is that he has a significant comorbidity like factor V Leiden, and he was on Eliquis medication, which he was reluctant to remove because he had already fulminant thrombolism of coronary vessels. I haven't heard of that already, probably due to his supplementary diet. And so he just wanted to have this treatment under full anticoagulation therapy. So that is basically his outline of this. So 3 full packs per day, incontinence, nocturia 3 times, ICIQ high, and IPSC surprisingly little. Of course, the IEF was still good, and the prostate size was considerably low in ultrasound, 27 ml. So I think we have an MRI of that as well on the next slide. Okay, there was his PSA, so there was nothing very problematic in this regard. And that was, I think, the MRI is quite nice to see. So we have on one hand the sagittal view, which was really a small prostate, more or less. And on the other hand, the coronary view also revealed just a subtrigonal, more or less small prostate. So again, so what to do with this case? He had a severe storage symptoms, and he had quite obstructive symptoms. He was diagnosed with diffuser underactivity. So the question is, what would we do with such a patient? I listed up all of these options. So a question is out to everybody.
So Stavros, you were keen on this good intervention radiologist. Would you send him for embolization then?
No, I don't think so. Actually, we don't have any data on patients with predominant storage symptoms. Sorry, Thomas, because I think I missed one slide. Did you do urodynamic evaluation of the patient?
Yeah, he was by the 4th urologist. It's a center of reference for urodynamics, and they found diffuser underactivity and obstruction.
Okay. And he was under medical treatment with alpha blockers and the muscarinics,
nothing worked.
Oh. This is the case, it's uncharted waters, more or less. So, yes, I think we should have the kind of discussion with him. Maybe we can go to de-obstruct the patient. It's a small prostate, so we can do a BNI. I think it could be an option. And then we could re-evaluate the patient after that to see how the storage symptoms, if they persist or not. I think this would be a first option. To discuss about the patient, the possibility to obstruct the first and see then if we can deal with the storage. But obviously, we should discuss beforehand that most probably he will need a second treatment, medical or another one.
Yeah.
So, Thomas, you were also involved, I see here, in the guidelines. So, what is your observation from this with these high-risk patients?
So, on one hand, we have a recommendation for small prostates which we had in this case, incision or TURP. And on the other hand, we had this severe bleeding disorder, which we have to encounter during surgery. And it said laser vaporization, so mainly green light, that's the data for green light. And on the other hand, laser enucleation. And I think this is why it came to be. I actually did the same as Stavros said. So you will face two treatments, basically. Probably we have to deobstruct you and then see how it goes with the better storage symptoms. And he received a transurethral enucleation in my clinic because he insisted on that. And it worked well. We did not need any Botox after that. Unfortunately, and this is the bad news, after 6 months, he got a bladder neck contraction. That's it. So we have to go for a second round as a bladder neck incision. I think the reason for that was his chronic inflammation of the prostate and his detrusor underactivity. And even if a patient looks like younger than you, so he looked basically younger than me, I'm 50 years old, but in the end, his tissue is 83 years old. So that's what I took out of this case. So don't let yourself be taken away by the physical presentation of an 83-year-old patient that has taken medication for 45 years, because after surgery he would probably look a little bit more like his age.
Yeah. So I think in the 5 cases, what all of you highlighted, it's not just about the resources that you have. You need to use your brain, communicate, and there should be a skill set, not just a resource set. And in this case, the last case, it's a challenging one. And obviously it goes beyond just treating his prostate with whatever there is. And in every treatment, you can go to either way of these. There is not always the best, but there are several that may be the best nowadays with all kind of treatments that are available. So let's